Okay, I'm ready.
You're ready. So if
Yeah.
you've read and understood considering surgical procedural skill station, please tell me how would you prioritize these three patients for OT listing?
Okay, so first on the list will be the strangulated inguinal hernia,
Okay,
and then next on the list will be the vertical abscess,
just continue,
and then
please.
the last on the list will be the MRSC positive patient
Okay,
with diabetes.
so you want to continue or keep the listing as it is. Why?
I'll keep the listing as it is because I want the strangulated inguinal hernia to come first because it's a bowel saving, it's an emergency and a bowel saving procedure.
Okay, considering the National Confidential Inquiry into Patient Outcome in Death, NCEPOD, listings or the criteria, how would you categorize number one, strangulated inguinal hernia?
Number one will be immediate surgery.
Is it immediate?
Yes,
No,
immediate.
it's not.
Okay.
It's a bit 1B, less than 6 hours. So there
Okay.
could be ischemic bowel or all the bowel obstruction. So here it's strangulated inguinal hernia. So bowel loops are obstructed or strangulated. So it should be operated in less than 6 hours. Okay.
Less than 6 hours. Okay.
So please tell me what are the current guidelines when you have to consider your patient number three that you want to keep. Number three is insulin dependent diabetic patient. Why do you want to keep it as number three?
Okay. First of all, because the patient is MRSA staff positive,
Positive, yes.
so and is a contaminated case, so that's why I want it to come last. And then secondly, also the below knee amputation is an elective surgery, it's not an emergency.
Okay, but your patient is insulin dependent diabetic patient. So what are the NHS guidelines when it comes to diabetic patients, like pre-operative guidelines for diabetic patients?
Okay.
How should they be
Preoper-
managed? Yes, please.
Preoperatively, there is no compulsion to admit the patient prior to surgery, and then we'll need to do HbA1c, blood sugar, and then patient will only need to omit the morning's dose. That's if the patient is on oral hypoglycemic agent,
Yes, continue, please. Two
and
more.
then subsequently the
Yes,
patient will have to be prioritized on the list.
yes,
And then if the patient is on insulin, then
yes,
the patient will have to be on insulin grading scale.
yes.
And then during the surgery, we'll have to monitor the blood sugar hourly.
Okay, if your patient is on insulin infusion, what are the new NHS or guidelines that you have to follow or
Okay.
that you have to keep in your mind?
I'll have to monitor the blood sugar hourly, making sure that it stays within the range of 6 to 10 millimole per liter.
And and patient should only is expected to miss one meal,
One,
not more
yes,
than
1
one.
meal.
This is
One
something which
meal.
I was looking for. Okay,
Okay.
right. Since your number one patient is also COPD and has a pacemaker, so what are the extra precautions that you should note down or you should inform your theater team?
Okay, first for the COPD, preoperatively, I'll counsel the patient to stop smoking, and then if there is any chest infection, I'll treat. Then intraoperatively, I'll prefer regional anesthesia to general anesthesia because of the increased risks of delayed recovery after the
Okay.
surgery.
Hmm?
And then
Yes.
also for the surgery, I'll prefer an open surgery to a laparoscopic rather than a laparoscopic surgery. Then postoperatively also I'll encourage chest physiotherapy. I'll
Very
also
good.
do
Yes.
intensive pyrometry. And then I also speak with the ITU registrar in case of the patient needs an ITU admission post-op. And then for the pacemaker, preoperatively, I'll assess the pacemaker, and I also like to speak with the pacemaker clinic to inform them that the patient will be going for a surgery to get an advice from them. Then intraoperatively, I'll make sure there is a CPR available in the theater. And then there's also a temporary pacer device and an ECG also to monitor the patient. And then I'll prefer to use a bipolar rather than a bipolar rather than a monopolar. Then if I must use a monopolar, then the receiving plate has to be away from the surgical site. Or
not from the surgical site, especially from the pacemaker, as far away as possible.
Okay, far away from the pacemaker, sorry.
Yeah. All right. Please tell me, your second patient is allergic to penicillin and iodine. How would you take care of that patient?
Okay, so during skin preparation, instead of using iodine, I'll use chlorhexidine. And then the antibiotics of choice, since the patient has penicillin allergy, I'll go for vancomycin or erythromycin.
Okay. Your last patient, diabetic patient, is also suffering from atrial fibrillation, for which patient is taking warfarin. So how would you manage that patient?
Okay, first of all, I'll consult with the hematologist and then get to know about my trust guidelines. Then I also like to classify the patient into high risk, high thromboembolic risk and low thromboembolic risk. If the patient falls under the low thromboembolic risk, I'll stop warfarin 5 days prior to surgery, and then I'll restart warfarin postoperatively as soon as the patient can tolerate orally. But if the patient has a high risk for high thromboembolic risk, preoperatively, I'll stop warfarin 5 days prior to the surgery and start the patient on low molecular weight heparin.
Very good.
However, I'll stop low molecular weight heparin 12 to 18 hours before the surgery. And then after the surgery, after accessing every bleeding risks, and when there's reduced bleeding risks, I'll restart low molecular weight heparin 6 hours post-operatively until the patient can tolerate orally, when I'll start warfarin.
Very good.
Then I'll take off low molecular weight heparin as soon as the INR is between 2 to 3.
Okay. What is one thing that you'll make sure this first patient with COPD is doing? So what is one thing that you'll make sure before you'll take this patient in the theater, operation theater?
Incentives spirometry.
A patient is COPD. So when was the last time patient took steroids?
Yes,
what was the dose? Why?
Okay, because if the steroid dose is less than 10 milligram per day, then there won't have to be any modifications. But if it's greater than 10 milligram in 24 hours, then I'll have to induce, before the induction of anesthesia, I'll have to give 100 milligram of hydrocot IV.
Yes.
And then after that, I'll maintain with 200 milligram over 24 hours.
Yes.
Then depending on if the surgery is a major surgery or a minor surgery. If it's a minor surgery,
How would you categorize this surgery? Is this minor or major?
Minor, inguinal hernia. Oh no, it's
not minor.
it's not
Strangulated
minor.
or minor.
Yeah, strangulated. Yes, it's major.
Major, because patient is COPD and non-pacemaker as well. Okay. According to the NICE guidelines, how would you classify the wound? Clean, contaminated, and dirty. Based on what?
For case number 1.
Yes. Or rather, case number 3.
Case number 3.
Okay, the one as well. Okay, how would you define? Because this is strangulated inguinal hernia. How would you say which category of wound is that?
Clean contaminated.
It's clean contaminated, yes.
Clean contaminated.
Or contaminated. Yeah, clean. Bowels are
The bowel will be
not
breached,
clean.
but we're not expecting any
It's contaminated.
soil. Yeah.
Thank you. Good.